Uh, Very good morning, all of you. We are once again welcome you to this webinar series organized by the Society for Health Research and Innovation in our series of educating our primary care practitioners on timely topic. Let me get on to some housekeeping rules. The webinar link will be available from 9 a.m. to 9:50 a.m. to join in. No late Uh, no late attendees will be entertained thereafter. Each attendee should have been attended till the end of the webinar to obtain the certificate for CPD points, and the CPD points are strictly adhered to the NCCPD guidelines. Uh, if uh, if anyone wants to ask any questions, if you have questions, please type into the chat function. If you have very specific questions about your situation, please don't hesitate. Please email us on officeshri13@gmail.com. Today's topic is my child safe? Child abuse and child safety, conducted by Dr. Darshani Hettiarachchi, the consultant child and adolescent psychiatrist, the Lady Ridgeway Hospital for Children.
So, good morning, everyone. I am Dr. Darshani Hettiarachchi, consultant child psychiatrist at Lady Ridgeway Hospital for Children. I hope you all can hear me clearly. So, why did I select this topic? Is my child safe? Actually, uh, as doctors, we might think that our children are safe and we don't have to worry much. Since we are doctors, we don't have to worry much about our kids' safety. Yeah, sorry for the inconvenience. So, what I was telling is that sometimes the doctors, like as doctors, we might think that our children are safe, so we don't have to worry much about their safety. However, as a child psychiatrist, what I have said, like child abuse is not that uncommon. It is commonly happening all over the country, all over the world. So, it's very important for us to, as parents, living like as parents, as doctors, to look after our kids and assure their safety. So, before starting my presentation, let me give you a couple of clinical scenarios. So, this 6-year-old girl, mother is a healthcare worker, mother attended a workshop on child abuse, and after listening to that presentation, she got alarmed about child's paternal grandfather's behaviors at home. And actually, the mother was worried that this paternal grandfather has been looking after the child since very young age, but this mother has noticed some like different deviant behaviors, suspicious behaviors in the grandfather. However, since grandfather had been looking after the child for longer period, mother has not been worried. But after listening to the presentation about the child abuse, she has got alarmed, and once she has seen some um, like bite marks on the 6-year-old girl's breast, and then when she inquired on it, she got to know then there had been chronic repeated sexual abuse by this paternal grandfather for a longer period of time. So that is one case. And this case number two, 10-year-old girl, both parents are medical officers. Child presented with recent onset behavioral changes, and and child has not revealed anything. However, parents have noticed recent onset behavioral changes like poor sleep, child was saying nightmares, was irritable, crying without a reason, and then child was brought to the child psychiatrist just for an assessment for these behavioral changes. And there it was revealed that the child had been repeatedly victimized, sexually abused by the swimming coach. This is the case number three. Here, the 7-year-old girl from an affluent family presented with school refusal, excessive crying in the morning, refusing to go to get ready to go to school. So since the child has moved to new class, and after that child has developed features of school refusal, and then the parents have thought this may be due to the Like this may be due to the teacher's strictness, or maybe the teacher is punishing in the classroom. So they have suspected about the class teacher. And anyway, since the child was having school refusal, they brought the child to the child psychiatry unit. And usually, when we see a child, we always get a report from the class teacher. But the history was very much suggestive of some kind of a, unpleasant experience in the classroom. However, when we got the teacher's report, what the teacher was mentioned, like what the teacher has written, was like child was happy in the classroom, doing school work well, but start crying when she has to go home, like when she has to leave the school. Then the teacher was worried whether the child is having some difficult experiences in the home environment. But then when we assess the child, we got to know that this child had been sexually abused by the school van uncle. So now we all can figure it out. Like child was scared to get into the vehicle. That is why she was refusing to go to school in the morning. And then when she approaches the school there where she feels comfortable, there she is happy doing the school work. But when the time comes for her to again get into the van at the end of the school, then she start crying and refusing to come back. So likewise, in many instances, we may not consider this victimization of sexual abuse in children, and we always think that our kids are safe. But what I wanted to highlight is that there are things that we have to be alert. And so there are some myths related to sexual abuse in our country, which increase the risk of victimization of children. One is like we tend to believe that only the girls get victimized. No, we have seen many boys are getting victimized. Actually, due to this myth, like like the families always tend to protect the girl and just not paying enough attention on the safety of the boys, which can result in them getting to risky experiences. And other thing is like you don't have to worry if the child is very small. Sometimes the parents tend to think child is very small, even the body is not like big, so we don't have to worry. No, the youngest girl whom I saw with the victimization of sexual abuse was 9 months old, so that the child doesn't need to grow up to be a victim. And the other most common belief what we have is that these are done only by strangers. And we always tend to believe that if the child is with a known person in known environment, we don't have to worry. But studies have shown, not only in Sri Lanka, in globally, majority of the sexual abuse occurs in known environments by known people. And the other belief is that we tend to believe that we don't have to worry much. Those are the things happening in low socioeconomic families. No, if you can remember the cases which I mentioned, a child from any socioeconomic background can be a victim of child sexual, especially child sexual abuse. So let's move on to the theory component. So, what is child maltreatment or abuse? According to WHO definition, child maltreatment is the abuse and neglect that occurs to children under 18 years of age. It includes all types of physical, emotional ill-treatment, sexual abuse, neglect, negligence, commercial or other exploitation, which results in actual or potential harm to the child's health, survival, development, or dignity in the context of a relationship of responsibility, trust, or power. So again, it can be either physical, sexual, emotional abuse or neglect, or exploitation, such as child labor, child trafficking, intentional drugging and poisoning, Munchausen syndrome by proxy, and conscription of children to harm. So, what is physical abuse? Non-accidental physical injury to a child caused by a parent, caregiver, or other person responsible for a child and can include punching, beating, kicking, biting, shaking, etc., or otherwise causing physical harm. may be a deliberate act to harm the child or attempt to discipline the child. I think if you can focus on this component, we still see many parents and teachers tend to physically punish or physically assault the children with the purpose or with the intention of disciplining the child. They tend to say that we want to discipline the child by using the methods of physical abuse. However, now you can understand that according to the WHO definition, no one can assault child with the purpose of disciplining the child. I think now, according to the law, now that the corporal punishment is not there anymore. However, still we see in my clinic maybe 2, 3 children coming with physical victimization of physical abuse by the class teachers. Still, this is very commonly happening, and as parents as well as doctors, we should not let this happen. And what are the signs of physical abuse? If we see a child in either in the private sector or in the OPD or in the pediatric ward, sometimes they might not tell that they were assaulted by the adults. So, in many instances, it can be an incidental finding by us. If we have the knowledge, we can be alarmed and we can try to find out whether this is due to physical abuse. So, what are the common features or kind of features which lead us to suspect whether there had been any kind of physical abuse? A child may have unexplained injuries such as burns, bites, bruises, broken bones, or black eye. Inconsistent history. That is, with the history, we are unable to, like one person will tell something, the other person will something else, and with the history, we are unable to work out what has happened. And again, the history is not compatible with injuries. That is, we are unable to explain the wounds with the history. For example, just imagine a mother comes and say that the child is having a cut injury on the right hand. And when we inquire, the mother may say that the child was trying to cut something using a knife and then he got injured. Child is a right-handed child. Just think, how can a child get a cut injury on the right hand? So likewise, sometimes the history may not be compatible with the injuries. Another feature may be multiple injuries with different stages of healing and delayed presentation. Just imagine if a child is having a fracture and parents have not taken the child to hospital for a couple of weeks, then we have to be alarmed. And a child may be seems scared, anxious, depressed, withdrawn, or aggressive. Uh, when child has to leave the hospital and seems frightened of his or her parents and protest or cries when it is time to go home. And the other feature may be the reports injury by a parent or another adult caregiver. They do not let the child to speak or the caregiver or the parent in only talk. Some features when we see a child in the OPD or in a pediatric ward for us to be alarmed whether this injury is a non-accidental injury. Now let's move on to the most important part, that is the sexual abuse. So the sexual abuse is defined as involvement of dependent, developmentally immature children and adolescents in sexual activities that they do not truly understand and to which they cannot give informed consent and which violate accepted social norms and family roles and which are against the law. So, according to the law in the country, any child who is less than 16 is considered as not having the capacity to give consent to have sex. So, child may come and say that I gave consent, or child may say that I enjoyed it. However, according to the law, if the child is less than 16, the law uh, considers this as the child doesn't have the capacity to give consent to have sex, so it is considered as a statutory rape. There are two types of sexual abuse. One is the touch type, and the other one is the non-touch type. So I think I don't have to explain about the touch type, where actually some kind of physical uh, contact has happened. In non-touch type, there may not be having any physical contact, but things like weaving the child's genitalia without physical contact, indecent exposure of the adult's genitalia, using a child to produce child pornography, seeing sexual services of children, and displaying pornography, pornographic videos, all these things can come under non-touch type of sexual abuse. The problem with the non-touch type is usually we do not have enough physical evidence to prove this. Only the child's statement will be there. So if the child is very young, if the child is unable to express what has happened, then we might not be able to gather enough evidence to prove that there had been any kind of uh, sexual abuse. And the other problem is when there is like the common myth what we are having in our countries, we always focus on the virginity of the girls. So if the victimization is a non-touch type, most of the time what we see the parents tend to ignore or the disregard it, saying that nothing has happened to the girl, so we don't have to worry about it. But as child psychiatrists, what we have seen and what the studies say is that irrespective of whether there is any touch or non-touch, the psychological impact after victimization of child sexual abuse is very much advanced. So we can't just ignore the non-touch type, saying that we cannot underestimate the gravity of the adverse consequences of non-touch type of sexual abuse. So again, as I mentioned earlier, in most instances, these things are happening in known environments by known people. So some children may have experienced it for longer period. And sometimes some children are not aware whether this is something wrong. And some children may not aware that even though they feel that there is something wrong with the behavior, they don't know how to seek help. So most of the time, these kind of victimizations are underreported. According to the National Child Protection Authority, what they say, one in seven, only 1 in 7 cases are reported in the country. So the rest of the six are going underreported. So, in most cases, this victimization of child sexual abuse, again, we find them as incidental findings. So, for us to be alarmed, there are some like features for us to be alarmed whether there is any kind of child sexual abuse has happened. Common ones like child may present with difficulty in walking and sitting, and again experiencing bleeding, bruising, swelling in the private parts, but they are very obvious features. And foreign body in the vagina. If any child presents with a foreign body in the vagina, we have to be suspicious. There are many reasons for kids to come with foreign body in the vagina. For example, if a child is having ADHD, the attention deficit hyperactivity disorder, sometimes due to the impulsivity, they tend to insert foreign bodies into their orifices. It can be 1%. But sometimes, after victimization of child sexual abuse, children tend to feel this as pleasurable. So if they have experienced any kind of pleasurable experience with the victimization, they tend to do the same thing again and again to get that pleasure. That is also something which we have seen. And the third thing is sometimes the perpetrator insert things into the vagina to conceal the evidence. So whenever we see a child who comes with some kind of a foreign body in the vagina, we must exclude uh, victimization of child sexual abuse. The other behavior is the sexualized behaviors. Whenever we see a child coming with sexualized behavior, we must exclude victimization because we see many young children do present with sexualized behaviors. Actually, how it happens is when they just do something, when they like when they are uh, like when while they are playing, while they are rubbing their legs somewhere or something, they tend to experience some pleasurable activities. And with that pleasurable experience, kids can continue this behavior, which can become a sexualized behavior. So, which is a normal behavior where we use some behavioral management techniques to control that behavior. However, we before excluding sexual abuse, we straight away never go for this behavioral management. So what I want to highlight is whenever we see a child coming with any kind of sexualized behavior, we may be 100% sure that the child was safe. Still, we need to exclude any kind of victimization. If we are 100% sure only, then we have to go with the behavioral management to control that behavior. And then painful defecation or with or without PR bleeding. We see this especially in boys, especially boys who are coming from institutions, religious institutions, where after anal intercourse they tend to have anal tears, anal bleeding, and also chronic constipation. So it's very important whenever you see a boy coming with PR bleeding, chronic constipation, just to ask a couple of questions whether there had been any kind of victimization. And reports nightmares or bedwetting because I think you all are aware secondary nocturnal aneurysms can be a presentation of victimization of child sexual abuse. And also, if a child demonstrates any kind of bizarre, sophisticated, or unusual sexual knowledge or behavior, we have to be alarmed. But we must try to find out. We must think about how the hell this child got this information. So we can't ignore these kind of behaviors in children. And obviously, if the child get pregnant or contract sexually transmitted disease, I am very sad to say. Recently, I saw a girl who was 2 year old presented to the Lady Ridgeway Hospital with UTI. And then during the examination, it was revealed that the child was having some kind of a genital ulcer. And then child was referred to the dermatologist. And then it was diagnosed that the child was having herpes simplex virus type 2. So imagine this 2 year old girl. So that is why I always say that these are the things which are happening commonly, and sometimes we are unable to pick them. So, what are the common feelings of sexually abused children? They are very scared. They may be feared, and as I mentioned earlier, most of the time these things are done by known people in known environments. So they tend to they may be very fearful, and also they sometimes these abusers or the perpetrators may have threatened the children. Most of the time, we see it like they tend to. Um, like they threaten the child, saying that if you tell this to someone, I'm going to kill your parents. Likewise, so they are very scared. Second thing is the guilt and shame because children tend to blame themselves, saying that they can't always they may think that whether I have done something wrong, and sometimes they may think that something bad happened to me. Because of that, they may have a guilt with them. And also, after reporting, as I mentioned earlier, most of the time, uh, the victims the perpetrators are known to them. And just imagine if the perpetrator is the father and the sole breadwinner, if the child reports about this and the father has to go to the jail, then the whole family setup will be disturbed. The younger children will not have food to eat. Younger children will not have a place to stay. Likewise, if they have to face a lot of adverse consequences after reporting, these children will carry guilt and the confusion. Sometimes children can experience these events as pleasurable. So if they have experienced any kind of pleasurable feeling, then they tend to get confused because most of the time these perpetrators they tend to use grooming. That is, they do not approach the child forcefully. They use different techniques to get the child's attraction, get the child's attention slowly. For example, I saw a 6 year old girl who has gone to her friend's house to go to the Sunday school, and that day, that friend was not there. And this friend's grandfather, who was in his 70s, he has asked this child whether she wanted the Mari biscuits, and this man has kept this little girl on his lap and given Mari biscuits. And while the child was eating Mari biscuits, this man has started touching and abusing the child. So likewise, in many instances, perpetrators they use different tricks to approach the child without using forceful measures. So with that, sometimes children tend to get confused whether it was a bad behavior or a normal behavior. And also, some children, after experiencing these events, they can develop depression and uh, get isolated. Emotional abuse. Again, something which is happening in our setting. Like I think we as parents, we most of us are doing this. The problem is we can't elicit emotional abuse. And children will never complain about the emotional abuse. However, the damage what we are doing with the emotional abuse is going to last forever in their minds, and it will reflect, yeah, even if they become adults, especially in their personality, in their problem solving skills, their coping skills, in their how they develop, creating the personal relationships with others. So it's very important to be aware about the emotional abuse also. So emotional abuse is the failure to provide a developmentally appropriate supportive environment to a child, which includes uh, constant belittling and blaming, shaming, rooting, labeling and humiliating a child, calling names and making negative comparisons to others, and telling a child that he or she is no good, worthless, bad, a mistake, frequent yelling, threatening or bullying, inappropriate or excessive demands. For example, you have to become the first in the class this term. Some kind of, like, excessive demands. And sometimes some parents tend to say, like, your brother got this much of marks, and you must get that marks likewise. And ignoring or rejecting a child as punishment and withholding communication. I have seen many parents, sometimes kids come and say, I was very sad, my mother told me that she was not going to talk to me for 2 days. Imagine if somebody comes and, I mean, someone who loves us come and tell that I'm not going to talk to you for 2 days, how would we feel? So the kids, they feel the same way we are. The thing is, we don't think about their emotional needs. Unlimited physical contact with the child, like no hugs, kisses, or other signs of affection. Sometimes I have seen many parents, what they would say, "No, I'm not going to give you a hug for 2 days. I'm not going to give you a kiss for 2 days. I'm not going to sleep with you for 2 days." Likewise, they are rejecting the children, and which can affect their long-term psychological well-being, and exposing the child to violence or other abuse of others, and destruction of personal belongings. Sometimes I have seen some parents, when they get angry, they tend to destruct the child's belongings, which is really bad, which can have very severe negative impact on child's psychological well-being. So the neglect. Neglect is the failure to provide for the development of the child in any spheres, for example, health, education, emotional development, nutrition, shelter, self, safe living conditions, in the context of resources being reasonably available to the family or caretakers, and causes who has a high probability of causing harm to the child's health or physical, mental, spiritual, moral, or social development. So, according to the definition, like for example, if the parents have the capacity to provide those things, and why, even despite having the capacity, if they are not providing, then we consider it as neglect. For example, if a manual laborer is earning 500 rupees per day, and if he can only give one meal per child, that is not neglect, because that is his capacity. But imagine if a high-end engineer or somebody has enough money, has everything, but he is not paying much attention on the child's health, then we have to consider it as neglect. So it's always, despite the parents having the capacity to provide the support, and if they are not giving that adequate support, is considered as neglect. Exploitation. Commercial or other exploitation of a child refers to use of the child in work or other activities for the benefits of others. This includes uh, child labor. According to the law now, if a child is less than 18, cannot be used in any child labor, and child prostitution, child trafficking, intentional drugging and poisoning. We see this intentional drugging in many beggars because we see many if you have noticed, when we are like driving in the road, we see many mothers who are like, I don't know whether they are real mothers, like, and they are carrying their biological kids. However, we see many females carrying small children, and if you notice, most of these children are always sleeping. Not that because they are drugged. So it's a common thing which is happening in our country, and Munchausen syndrome by proxy, where the caregiver is inducing some kind of symptoms in the child to get some benefits for themselves. Again, a common thing what we see in pediatric, not very common, but we see it in pediatric wards, and constriction of children to arms. Going back to Munchausen syndrome by proxy, actually very recently we had a girl, 12-year-old, 10-year-old girl. She was in the pediatric ward for 6 months with pyrexia of unknown origin. Actually, child was having very high fever spikes, 103, 102 degrees of uh, Fahrenheit, and the pediatrician and the pediatric team were unable to identify the reason. Child has been extensively investigated and given all the medicines. However, child has not recovered, and continuously child was having high fever. And then one day, this the child, the young nursing staff, she has asked usually in the pediatric wards, I'm not putting a blame on anybody, but due to their busy schedule, in the pediatric wards, the nursing staff tend to give the thermometer for the parents to just check the temperature. So here also the same thing has happened, and after a couple of minutes, this mother has shown the nursing officer that the miss, she's having 103 degrees of fever. And when the nursing staff just touched the child was not having any fever. Then this nursing staff has asked the mother, she's not having temperature. Then the mother has told, no. Usually she get high fever spikes even without rising body temperature. So this nursing staff was a little alarmed, and she has told, no. Anyway, I will check it, recheck. So she has put the thermometer back, and she has waited and checked the temperature. It was just 99 degrees. And when she showed it to the mother has told, we will keep it as a secret. Then the whole boat got alarmed, and then they started thinking whether there is something going on. And when and the mother was referred to us, actually what has happened, this mother and child, they are coming from very far away place. This child's father was a like heavy alcohol user, actual alcohol dependent person. There were ongoing domestic violence. This person has destroyed everything in the house. Doors were broken. So in most of the night, this mother and child had to stay outside in the jungle to get themselves protected from this father's abusive behavior. So actually, this child had got the fever, and she has got admitted to the pediatric ward. But the pediatric team has treated this mother and child very well. With that, they have become institutionalized, and they were feeling very comfortable there. So they didn't want to go back home. So that was the reason for the mother to self-inflicting fever spikes in the child. Actually, what the mother has done, she has used a hot cloth to uh, increase, showing increased temperature in the thermometer. So actually, at the end, we supported the girl and the mother with the involvement of the child safety, probation, social services, and we managed to provide them a better placement. So those are the presentations of some kind of child abuse. So let's see what are the psychological consequences of trauma in children. In many instances, children do not they do not directly present, they do not tell the incident. And in most of the instances, they come with emotional and behavioral problems. So we just see a child coming with emotional and behavioral problems, and when we try to when we get the history and when we do the assessment only, we find that there have been any kind of victimization has happened. So what are the common behavioral and emotional problems? They can become angry, irritable, fear, worries, crying, poor sleep, appetite, re-experiencing the event, nightmares, changes in heart rate and breathing patterns, that is autonomic arousal, withdrawn behaviors, and also sometimes they can come with poor school performance. So, whenever you see a child who's having recent onset behavioral changes, this victimization of child abuse should come as one of your differential diagnosis. So, what are the psychiatric conditions after victimization? They can have acute stress reaction. They can have acute stress disorder, post-traumatic stress disorder, adjustment disorder, depression, anxiety. And also, various studies have shown that after victimization, children can have increased suicidal risk even if they become adults. And also, they can have substance-related issues even if they become adults. So these victimizations can have negative impact on their personality development. They can present with low self-esteem, low self-confidence. And the most important thing which I want to highlight is they can have negative impact on their interpersonal relationships even as adults. The reason is, as I mentioned earlier, like most of the time the perpetrators are known to them, and the child trusted was the one who hurt the child. So they develop trust issues. They tend to mistrust other people because they find it difficult to trust others. The person whom they trusted most did this bad thing to him. So they develop trust issues. So when you cannot trust other people, it can affect our interpersonal relationships because you can imagine whatever the interpersonal relationship which we are having, for example, the relationships which we are having with our colleagues, with our workmates, with our friends, with our family, with our partner, with our child, whoever, the trust is the most important thing. So if we can't trust other people, then it will be very difficult for us to maintain interpersonal relationships. And the other thing is the circle of abuse. That is, the victims can become abusers when they become adults. There are many more psychosocial consequences, but due to the limited time factor, I do not have time to discuss them more. So, what are the factors which determine the development of psychological consequences of trauma in children? These it depends on the perpetrator related factors. If the perpetrator is a stranger, if the child has experienced some kind of a violent encounter, then the psychological impact may be higher. And if the perpetrator is a parent, caregiver, the child will develop trust issues. And the victim related, if the child is very young and unable to understand the gravity, the consequences might be lower. And the developmental stages, if the child doesn't have the understanding about the event, it may lead to less psychological consequences. Gender-wise, females are at higher risk, and level of intelligence. If the child has low IQ, then the psychological impact may be low. And the temperament, that is the characteristics of the child. We see some children, they're very friendly, uh, happy. Some children are introverted and some children are having difficult temperament. So if the child is already having a difficult temperament, then the psychological impact may be higher. And the physical health of the child. If the child is having any kind of a physical health problem, that is, the child is already compromised, then the psychological consequences may be higher. And the mental health issues. If the child is already having mental health issues, the child is at higher risk of developing psychological consequences. Good support after victimization, then the psychological consequences may be low. The nature of the abuse. If the abuse event is very intense, violent, then the psychological consequences will be higher. And the repeated victimization can lead to more psychological symptoms, as I mentioned earlier, due to the limited reporting. And when the children do not report, they are going to live with the perpetrator. Then the victimization, repeated victimization can occur. So when there is repeated victimization, then the psychological consequences are high. And the other thing is the re-traumatization during the process of management. What is re-traumatization? Re-traumatization is generally used to refer to the reactivation of trauma symptoms due to an event or interaction that reminds victims of previous traumatic experiences. Re-traumatization occurs when a triggering event causes the victim to be overwhelmed by memory and feelings from the previous trauma. This is described as the psychological equivalent to having a scab torn off from a wound. Just imagine when we are having a wound on our hand, we can see when it get healed, there is a scab formation. Just imagine if we repeatedly remove the scab and try to look into the wound, that wound will never heal. So this is also like that. If we repeatedly ask questions from the child, if we repeatedly expose the child to the traumatic memories, that scab which is formed in our mind will not be properly formed, and the child will repeatedly experience the same uh, bad memories again and again. So who do this re-traumatization? Actually, we all are responsible healthcare workers, medical officers, nursing staff, supportive staff, any hospital staff. Because we go and repeatedly ask from the child, the nursing staff during their shift, during the handing over the shift, they tend to go and sometimes they hand over about the child in front of the child. So likewise, and the supportive staff. And then the social and the other services, probation, CRPO, social workers, and the police, legal, and the education system, principals, teachers. So what actually happens after victimization? People tend to ask about the incident again and again and again, which lead to re-traumatizing the child. So, what is the current management of child abuse in Sri Lanka? So, we have our national guideline for the management of child abuse and neglect, which was formulated by the Sri Lanka College of Pediatricians, College of Forensic Pathologists, College of Psychiatrists, Medical Legal Society of Sri Lanka, and an NGO. So, according to the national guidelines, the management of victims of child abuse has a multi-sectoral approach. That is, multiple stakeholders get involved in managing the child. Initial management should be in a hospital to address the medical issues, and ideally, a child should be managed in base hospital above. So, according to the multi-sectoral approach in managing a victim of child abuse, usually the victims may present to the hospital outpatient department. It may be an accidental finding at pediatric ward, or maybe uh, this was reported to the police or the National Child Protection Authority. However, after being reported, according to the guidelines, there are two types of case conferences have to be conducted. One is the clinical case conference. It has to be happen within 48 hours, but due to the practical issues, we usually do not go with this clinical case conference. We go with the institutional case conference where all the stakeholders get together and the who are responsible for managing the child. The pediatrician, child psychiatrist or the general psychiatrist, judicial medical officer, child protection, probation, police, social worker, uh, and the education. So all these people get together and we conduct this institutional case conference where we discuss about the assure the safety. We need to assure the safety, where we discuss about the placement of the child, and then the medical management and the psychological management. And we need to discuss about the school or the vocational training and follow-up plan. So, what are the objectives of multi-sectoral management? Provide immediate medical care in a secure environment, and the most important thing is to reduce re-traumatization and psychosocial rehabilitation and reintegration, uh, assess other children who may be at risk. Because whenever we see a victim, we always need to assure the safety of the other children in the same setting. If you can remember the child whom I discussed, the 2-year-old child uh, who was diagnosed with herpes simplex virus type 2, actually there were 4 other girls in the family, so we had to uh, get down all the children and had to get admitted to LRH for assuring the safety and for the assessment. And we always have to work towards holistic recovery. And the other important thing is to prevent further abuse and also to assess legal process for justice. And there are some tips as doctors. Whenever we see a victim, we need to uh, like focus on minimizing re-traumatization. So the first thing is to reassure the child, provide safety and privacy, and comfort the child. Speak gently to the child. Trusting relationship, confidentiality, sympathize the child, showing empathy, and zero tolerance. That is, uh, like there is no uh, like whenever we see there is nothing called mild, moderate, severe ranges in victimization of child abuse is child abuse. So whenever we see a child who has uh, come with like non-touch type of sexual abuse, we can't just say that it's just non-touch type and we can't send the child home without taking adequate precautions. And child should be spoken to by the appointed staff member. Ideally, one person should be appointed and only this person should talk to the child. And we should never induce guilt in the child because if you can remember during my previous slides, I mentioned that after reporting, the child may have to experience so many unpleasant experience. The whole family may have got disrupted. So child may be already having guilt. So we should never induce further guilt in the child. Uh, and we should not ask direct questions and the suggestible questions because by nature, children tend to believe that the adults know better than them. So if we ask direct questions where the answer is yes or no, they will directly mm, tell the answer. They assume that we want to hear. And again, be non-judgmental. We should never be judgmental about the victims. Uh, for example, like if the child is, according to the law in the country, if the child is less than 16, child does not have the capacity to give consent to have sex. So if the child has gone somewhere with somebody and has been victimized, we can never say that since you went out alone only that you had to experience this. We can never say like that. So, and since you put a lot of makeup, since you were wearing short skirt, that was the reason for you to got into this trouble. So we cannot be judgmental like that. And also, we should never label the child. I think in our country, due to various reasons, after victimization, even before the police and the other stakeholders get to know it, it's all published in the media. So then what will happen? We tend to label the child. The incident which happened in that area, the child whose information was reported in that TV show, TV channel. Likewise, we tend to label the children. So we should never label the children. The other thing is whenever the police officers, um, like when they try to access the children or when they transport children, according to the guidelines, it always says that they should be wearing civilian clothes and they should not use official vehicles to transport these children. How? Because whenever we see a child with a policeman wearing a uniform, people tend to look at the child as a offender. So to minimize that, and also children are also scared of that. To minimize that, uh, what the recommendation is always for them to wear civilian clothes. However, the problem is these national guidelines are just guidelines. They are not having any legal validity. So even if anyone who do not follow the instructions, we unfortunately we are unable to take actions against it. So this comes to my final slide. So whenever, as parents, as doctors, as civilians, whenever we get to know about a child abuse, there are three places where we can info. One is the Child and Women's Desk at nearest police station. We are also having a new helpline that is 1909, and the National Child Protection Authority. They are having uh, 24/7 helpline 1929. And also if you have any worry about the safety of a child, you can advise the parents to admit the child to the nearest hospital. So what are the things that we can do prevent child abuse? First thing, be aware as adults. The thing is we need to be aware, we need to be vigilant, and we need to spend time with children. Then only we will be able to find out what has happened to the child during the daytime. Any kind of strange information, any kind of strange experience the child has gone through during the daytime. And when we spend time with the child only, we will be able to elicit behavioral and emotional changes. And then to observe and detect behavioral changes, give age-appropriate sexual health knowledge. We should always teach the children about their safety. Good touch, bad touch, and when to say no, how to seek help, likewise. Always to be supportive and immediate reporting. So it comes to the end of my presentation. Uh, if you have any questions,
Yeah.
uh,
Uh,
I
Madam,
think
there
we
is
have
a
only 5 minutes. Yeah.
madam, there is a question.
Hmm.
Madam, what is the minimum age for compulsory school? And there is a few questions in same line. What is the minimum age for the compulsory school? Minimum age for the vocational training of disabled child. Then what is the minimum age for to be held responsible for legal offences? What is the minimum age for
Oh, okay.
sexual
Can you
activity?
slow down, please? Can
Yeah,
you
okay, madam.
let's go one by one? Yeah. First
Yeah.
one,
What is the minimum age for compulsory school?
age 60. In Sri Lanka, now we have to, child should go to school until age 60.
Yeah. And what is the minimum age for vocational training of a disabled child?
Well, it depends. There is no exact age, but if the child, like if the child is present to the multidisciplinary team, and if the child psychiatrist, general psychiatrist, pediatrician, and the occupational therapist, we decide that this child is more like suitable for vocational training, we can consider, but still after 60.
What is the minimum age for to be held responsible for legal offences?
Ah, so according to the current law, if the child is less than 12, the law assumes that the child doesn't have the capacity, doesn't have the criminal responsibility. So if the child is less than 12, no criminal responsibility. That is, the child doesn't have any responsibility for any criminal like what he has done. If the child is more than 14, then the child has the criminal responsibility. So whatever the act they have done, they are responsible for after 14. If the child is 12 to 14, then the child is produced in front of a multidisciplinary team where the child psychiatrist, judicial medical officer, and the clinical psychologist are in that panel. So then they decide whether this child is responsible or not, that whether we should give the clinical responsibility to this child or not.
And madam, what is the minimum age for sexual activity?
16, I told it.
16, yeah.
16 or no. Yes,
No.
16 is the age.
Yeah, and that's another question, madam. How to socialize the child after the abuse?
Well, it's a very complicated answer. After abuse, I mean, we have different therapeutic approaches. If you could remember that slide, psychological consequences. So they can have multiple psychosocial consequences. So we have to go with case by case basis. If the child is having treatable child psychiatric condition, anxiety, depression, we have to go with the pharmacological and psychological. Then we have other therapeutic approaches like trauma focused CBT. Well, so the different therapeutic approaches are there. So it's not just socializing. We have to go with the holistic approach. Socializing, ensure the safety, ensure the education, so many things. Yeah.
Uh,
Any other
yeah.
question?
Yes, finish, madam. Thank you very much, madam, for the give your valuable time for this lecture. Uh, Thank you very much, madam.
Thank you for giving me the opportunity.